we've listened to various expert presentations regarding surveillance and also regarding how you're using that surveillance. It'd be really interesting to see if they're using it across the devolved nations, because you said you'd used it, obviously, is it the NHS England area? And I was just querying, have you used it in Ireland, Scotland and Wales?
The idea was to do it together, so we approached colleagues from all 4 nations. Scotland and Wales said that they are not planning it due to resource issues. And also, on a more positive note, that they have introduced electronic prescribing across all hospitals, so that they will get this the antimicrobial usage component out of their system, and so it won't need to capture it sort of separately. So no, Northern Ireland was also interested, but then in the end also found it too much work. Because as I showed, it was a big and not the easiest of time for all healthcare systems across all 4 nations, with changing in patient record system, electronic records, etc., plus strike actions.
And how do you see this working long term with the results and benefits long term as well?
I mean, we are hoping to, I mentioned automated surveillance. I mean, we're not sure whether for the next round we would need to repeat a similar exercise in 4 or 5 years. And maybe it's not realistic to expect that by then the systems can automatically provide the data. But longer term, I think that's really the alternative, that nobody needs to enter or capture data separately, that hospital systems can be used directly.
Did you find that the clinicians interacted well with the data that you provided, and it was disseminated in a way that the people on the ground could understand that and work with that?
There were clearly during the survey period, first of all, the webinars where we sort of explained the rationale, there was a lot of interaction, so people were clearly interested, and then the actual survey period, we had a lot of interaction because definitions needed further explanations. The data capture system made it sometimes more difficult than expected. So now with the outputs, we asked what the best outputs would be, the most useful outputs, and the response was really the Excel spreadsheets to have the raw data available, plus then PowerPoint slides to be able to use it in team meetings. And feedback has been so far already that it has been used. And as I said, we had to issue a second version of the material because people had looked at it in a lot of detail and fed back that there were issues with deduplication algorithms. So yes, people seem to have used it.
Thank you. I think we just got one speaker over there.
Hi, I just wondered, you referenced that the data was going to be processed differently for mental health trusts that took part in the survey. And I wonder, is that going to inform separate data capturing for mental health, as it's very different with what perhaps we're trying to review and understand about AMR compared to the acute hospitals? The survey is looking at both the acute, independent mental health sectors, and you said that the data was going to be reviewed and processed differently for the mental health providers. So is that going to inform change of what is looked at, the data that's captured in the next PPS?
Maybe that wasn't clear. It was captured very much in the same way. Of course, when the forms that I showed, not everything there was relevant for a community health setting, so we have missing data there. And when I say the outputs are different, this is really just that we show it by mental health trusts and that they can compare it with mental health, so not with the overall HCI or usage figures, for example. So we have broken it down by trust type. So acute general hospitals will compare their data with acute hospital, and mental health will compare with mental health. And so otherwise the data capture system, etc., that was all the same. And the forms used, the data we asked for was the same.
Yeah, I was going to mention with the European PPS for HCAI, it was every 5 years. So 2012, 2017, and then last year it was a year delayed because of COVID. But the bliss about it is that we can benchmark, because in Ireland we don't have national surveillance, but now with the PPS results we can benchmark. So even your forms looks very similar, so hopefully we'll be able to benchmark with the UK as well.
Right, I've got a question, Lenora. So you're talking about care bundles.
Yes.
And I specifically predominantly work in the operating theatre, so I spoke to you earlier about surgical site bundles, so
Yes.
the surgeons, etc. So do you see this working with that, and have you looked at that, or is that an area that somebody has ever questioned?
As you all know, theatre surgical services are a very specific area, and absolutely they do need care bundles. But the key thing is to get the people involved with the development of the care bundles, and then to get them to adhere to the care bundles. So I think when I showed you the first two that we started off, we went for the simple ones that we always do. And with the peripheral care bundle, it was actually incorporated into our assessment form. So where we were doing those assessments, that's what we incorporated the care bundle, rather than having more information that the nurses have to tick. But absolutely, yes, that should be, maybe for the next conference I could look at that one.
The thing I was asking about the surgical site care bundles is that with a lot of the surgeons, some of them have specific ones, specific specialities.
Yeah.
But then when I've been looking at all the data we've been seeing and listening to the talks, what I was saying was all you need is one person to do something wrong within this bundle or not follow
That's
something
right.
correctly.
Yeah.
And then you've got the potential for an infection. And this is why it's important that the people on the ground understand that there is a bundle. So particularly in theatres, when I go around, when I ask, as a patient, on a bundle, they all look at you silly as though you don't know what you're talking about. It's not something that's discussed at a team brief or in the department. So none of the staff really know. We just do what we routinely do on a regular basis and hope and pray that everything goes okay and the patient doesn't get an infection. But I think it's important that we understand why we do what we do, when we do it, and the reasons for that, which is this bundle is quite important, because I've spoken to a lot of surgeons that have their own bundles and not working, but then equally there's others that aren't. So there's not standardisation across healthcare in general, and it's only a specific speciality. So I think it's important, like with your bundles that you're talking about.
Yes.
So when you mentioned about catheters, I had a surgeon who always put a catheter in a patient when they had an abdo-hyst. And I always asked the question, can you tell me why you're doing this? And he had no clinical reason why he was doing what he was doing. He just said he always did that. And it was so the patient didn't have to get out of bed. That was one of the reasons. And they would have a more comfortable night. He didn't mention anything about infection or obviously a patient, going into retention or any long-term issues regarding that. So I think it's important that we look at what we do and why we're doing it to patients in relation to that. But I also just want to one last question with regards to your bundles, is that with your bundles, when I was looking at things, you were looking at specific key areas, and there's also things around sort of with the catheters and what they're doing around that. Did you have any other issues within ICU in relation to the catheters? Because you talked about going on the ward and then they have the leg bags.
Yeah.
So how did you transition from that?
Well, again, that's a new project that we're just developing. We're just expanding it. So a patient in ICU is in the bed, so they're not up, they're not mobile, so it's easier to manage the urinary catheter. On the ward, it's completely different. So on the ward, so at home, again, urinary catheters are managed differently, but in acute setting, if they have an overnight bag, it's changed daily compared to ICUs every 7 days. So we're going to have to change our care bundle. But if we change it for the ward, it really needs to reflect what's going on in ICU, because it's all about standardization across the board. So we're just going to have to review particularly our number 5 measure. Yeah, so.
Thank you. Has anybody got any questions before we finish? Yes, I think your mic should work.
I have a question. You mentioned this on the last slide, so the impact on outcomes.
Yeah.
I would be really interested in seeing this, and maybe even this sort of drop.
Yeah, no, it would.
So
Yeah. Again, it's all very time-consuming to do all of this monitoring and surveillance. So our aim was to get the care bundle in place and to get the compliance up. But really, we should marry the outcome of the patient with the compliance of the care bundle, and also which measure was non-compliant. That would be a really nice project, but it's more time to do that. Yeah, and more resources.